Hello guys, welcome back to No More Cavities. Today we are discussing about the operative treatment in primary teeth. There are different options to treat a primary teeth, but depending upon the extent and type of caries. So the first that we are discussing are pit and fissure caries. If the pit and fissure caries are present, that means that the child is at high caries risk. Why? Because in primary teeth the pit and fissure caries are shallow, so there are no chances of caries to develop. But if the caries are developing, that means the child is at a high caries risk. So what we will do, first we will provide ALA, then we will remove the caries, and then we will seal the tooth. But we will not use amalgam for pit and fissure caries in a primary child. Then comes the approximal caries. So, in proximal caries, we do not use GIC, we do not use amalgam. Amalgam is not used because failure and because of its design. What do we mean by design? As we know that for amalgam we need a box-like cavity. So the amalgam can retain in it. But in primary teeth and molars there are wide contact area. So we have to form the box. But as the contact area are wide, we are unable to achieve a narrow box. The second reason that why we are not using amalgam is that enamel is thin in primary teeth. Enamel is so thin in primary teeth that if we try to achieve a box, we will probably crack the tooth. And the third reason that why we are not using amalgam is that the primary teeth undergo wear under occlusal stresses. So it will probably affect the restoration that will be present here. Then the third option that we opt for treatment is stainless steel crown. I have discussed stainless steel crown in a different video. I will be sharing the link in description. And the fourth thing that we deal are anterior teeth. What type of restoration we will be using for anterior teeth? So the treatment option for anterior teeth are strip crown. They are made up of celluloid and what we do, we use them along with the composite. What is the procedure? First we take the strip crown, we trim it. After trimming, we fill it with composite. And after filling, what we do, we seat it on the tooth. And we cure the composite. And when the composite is properly cured, what we do, we strip off the celluloid crown. But the strip crown is feasible under GA. We can also use composite in primary teeth if there is incisal edge fracture. Now we will be discussing the different procedures that we perform if a pulp is involved or it is about to involve. So the first that we are discussing is indirect pulp capping. What is indirect pulp capping? It is basically a biological approach in which we do not completely remove the caries. We just remove infected caries while removing some soft dentine there to protect the pulp. If we consider this is the tooth and these all are caries, this is the soft dentine, this is pulp. So what we will do? An indirect pulp capping procedure, first we will remove the caries. These all caries that are black in color, these are infected caries. We will try to remove these caries with slow speed, handpiece and round burr. After removing these caries, we will remove the infected dentine. But how we will know that how much dentine we have to remove? We will use dye. These dyes are indicator of infected dentine, and which dye we will be using? We will be using 0.5% basic fusion. So we will be using these dyes to know that how much infected dentine is present. After using dye, suppose we have removed all the infected dentine. This all dentine is removed. And this all above enamel caries are also removed. Now we are only left with the soft dentine present over the pulp. That is protecting the pulp and we are not removing it. What we will do, we will place calcium hydroxide all over the soft dentine. Why we are placing calcium hydroxide? Actually to reduce the microorganisms and to promote the formation of secondary dentine. After this calcium hydroxide layer, we will be placing zinc oxide eugenol or GIC. Then what we will do, after some weeks, we will re-intern the tooth and we will try to remove the remaining soft dentine. And seal the tooth with stainless steel crown, because stainless steel crown will provide the best coronal seal. Then we will be discussing about vital pulpotomy. What is pulpotomy? The removal of the coronal pulp. And leaving the intact radicular pulp. We will just remove the coronal pulp and we will leave the intact radicular pulp. So, when we are performing vital pulpotomy, the first step that we will be performing is to stop the bleeding. Bleeding will be stopped either using a medicament or a cotton soaked in a sterile saline. But if the bleeding persists, it means that the radicular pulp is inflamed. And if the radicular pulp is inflamed, we will go for two other options, but not for pulpotomy. We will go for either extraction, either for vital pulpectomy. And if there is no pulpal tissue present, then what we will do, we will go for non-vital pulpectomy. There is radicular inflammation and we are not going for either extraction or either vital pulpectomy and we are going for pulpotomy, then what happens? Internal resorption will occur. So, vital pulpotomy means that we are removing the coronal pulp, leaving the intact radicular pulp behind. And the first step that we are performing is to stop the bleeding. And when we try to stop the bleeding is persistent. That means that radicular pulp is involved. If the radicular pulp is inflamed, we have to go either for extraction, either for vital pulpectomy. But we are not going for both of these and we are going for pulpotomy. Then the chances are that the internal resorption will occur. So we said that we go for any type of medicament to stop the bleeding. Then which type of medicament should we use? We will be using ferric sulfate. It is the gold standard. For 15 seconds. How much concentration of ferric sulfate should we use? 15.5%, and it is an excellent hemostatic agent. It is also used to control the gingival bleeding as well, also used in endodontics. Metoprolol was the agent which was used before using of the ferric sulfate, but it was proved that it is carcinogen, so now it is prohibited. Ferric sulfate is a strong hemostatic agent. So what does it do? It hides the inflammation of the radicular pulp. Then what we will do? We will use the sterile cotton wool saline for the hemostasis. And after the hemostasis will be achieved, we will be using ferric sulfate. So what will be the procedure of pulpotomy? First will be LA and rubber dam. Then we will be removing the caries. After removing the caries, what we will do, we will remove the roof of the pulp chamber. Suppose this is whole the pulp chamber, we will remove the pulp chamber. While removing the pulp chamber, when we feel a slight dip like sensation, we will stop the burr here and we will not go further because we will be exposing the radicular pulp. This is the coronal pulp, and after feeling the dip, we will removing the sideways of the coronal pulp, and then we will apply ferric sulfate on this radicular pulp. After applying ferric sulfate on the radicular pulp, what we will do, we will be check if there is any hemorrhage or not. If there is any hemorrhage, we will repeat the process of the ferric sulfate. If not, then what we will do, we will fill the chamber with MTA, and then what we will do, we will place a stainless steel crown. So this is the procedure of vital pulpotomy. Now we will be discussing the process of pulpectomy. The pulpectomy can be either vital when we are removing the radicular pulp, or either non-vital when the whole pulp is necrosed and no live pulp is present. The vital and non-vital pulp differentiate from each other because in vital pulp we use H file to remove the pulp and the disinfection time is short. But the disadvantage of vital pulpectomy is that there is extra time needed and we require excellent behavior management. We perform non-vital pulpectomy when we are avoid to perform extraction, such as in orthodontic procedures, or when the patient medical condition do not allow us to perform the extraction, or when parent does not allow us for the extraction. There is any abscess tooth, there is any furcation pathology, and when the tooth is restorable with at least 2/3 of the root length remaining. The 2/3 of the root is remaining and the tooth is restorable. Then we perform non-vital pulpectomy. First we will give LA, then we will access the pulp chamber, and then we will first LA, then access. Then the third is to identify the canals. After identify the canals, we will prepare the canals, but we will not go more than file number 30. We will irrigate the canal with 0.5% solution of sodium hypochlorite and normal saline. We will dry with the canals with the paper point. Then what we will do, we will select the spiral root canal filler, 2 size smaller than the last file we use. It means it will be 2 size smaller than the 30 number file. Then what we will do, we will mix the zinc oxide eugenol slurry and we will put it in the canal with the help of these spirals. We can also put this zinc oxide slurry with the help of GP points. What we will do, we will fill the chamber with all the cement and then we will restore the tooth with stainless steel crown. Why we are using zinc oxide eugenol? Because these are primary teeth, and as the teeth will exfoliate, the zinc oxide eugenol will resolve with time. If there is abscess tooth, what we will do, we will perform the pulpectomy in 2 visit procedure. After preparing the canal, we will place calcium hydroxide paste and leave it for 1 week. Then the patient will come and we will remove the intracanal medicament and we will perform the procedure of pulpectomy by putting zinc oxide eugenol with a spiral within it. This was all about the operative treatment in the primary dentition. Thanks for watching.